The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is What to Know When You're Newly Diagnosed with Glioblastoma. Thank you to today's webinar sponsor, Medexus Pharma, for their support of this program. My name is Umbreen Mon, Program Manager at the ABTA, and I'm delighted to introduce our speaker. Dr. Daniel Cahill is Professor of Neurosurgery at Harvard Medical School and Massachusetts General Hospital. As a neurosurgeon scientist, Dr. Cahill has a strong lab research interest in improving treatment for brain tumors. His clinical practice is focused on the care of brain tumor patients, improving clinical trials of therapy for these patients, and training neurosurgical residents in the diagnosis and treatment of these tumors. Thank you so much for joining us, Dr. Cahill. You may now begin your presentation.
Thank you very much, and I just want to acknowledge the ABTA and the important role that you have played in the country, really, in the fight against this disease. And I really appreciate the opportunity to present at this webinar today. So the topic of my talk is what to know when you're newly diagnosed with glioblastoma. And really, I wanted to just cover in the talk today the basics, the high points of how we navigate the initial process of making a new diagnosis, and how to assemble the team as a patient and a family caregiver for somebody who is a loved one who has been diagnosed with glioblastoma. Glioblastoma, as we all know, is a serious diagnosis, so there's some very important things to make sure you get right as you come through this initial phase of diagnosis. These are my disclosures listed here. Glioblastoma usually presents in patients with common symptoms and signs. So patients will have either neurologic symptoms like seizure or isolated weakness, a weak arm or a weak leg, difficulty walking, difficulty with vision or spatial sense, or headaches. But sometimes glioblastoma will present with really no symptoms or unrelated symptoms that ultimately we don't think the tumor is causing these symptoms. So symptoms like dizziness, sometimes car accidents or minor accidents where patients get hit in the head, or memory difficulties. And then ultimately all of these types of symptoms will result in a workup that gets an MRI scan. And the MRI scan will then show an enhancing lesion, typically on the T1 post-contrast images, that is concerning for glioblastoma. And I think that this is the first key step in to talk about when we're making the diagnosis of a new glioblastoma. So we have several scans here which are suspected glioblastoma. So here's a tumor in the right insular region. Here's a tumor in the left parietal lobe. Here's a tumor in the right kind of sensory motor area. And these are all concerning for glioblastoma. And certainly the next step for these patients is to consider surgery as a treatment. But the most important message that I want to make with this slide is that actually none of these patients have glioblastoma. So they have mimics. They have things that are on the MRI scan concerning for glioblastoma, but are not glioblastomas. This is a stroke, actually. This patient did not have a tumor. This patient has a brain abscess. This was a suspected glioblastoma, strongly suspected, but was not. And this is a patient who has a pediatric tumor of pilocytic. So this is not a glioblastoma. And so really, the take-home message here is that an MRI scan alone is not a diagnostic image by itself. And so if you have an MRI scan that is suspicious for glioblastoma, it's very important to then take that next step and move towards consideration of a diagnostic surgical procedure. Surgery is the next step when you have an MRI scan that is suspicious for glioblastoma. There's really two goals. So as a neurosurgeon oncologist, and this is what our mainstay of practice is we see patients who are in this newly diagnosed setting. They've had symptoms or not, that has an MRI scan that is concerning, and we need to move towards surgery. There's really two important goals for that first surgical procedure that we're thinking about for patients. The most important, or the first goal, one of the goals, is to say we have to secure the diagnosis. So we have to move away from this possibility of glioblastoma and be really certain that that's what this is, because it's a serious diagnosis. So you have to be 100% certain that that's what it is. This is critically important. There's really two components to the diagnosis of glioblastoma. One is the traditional or legacy component, which is histology. And this is where we take a small piece of the tissue and we give it to the pathologist who prepare it and stain it and look at it under the microscope using both traditional methods and then these newer staining techniques. And they look at the tissue architecture of the cells and see if it has the characteristic appearance of glioblastoma. In addition, in the modern era, so basically after 2016, we look at additional molecular features that are tested on every case. These are the IDH mutation, MGMT methylation status. TERT promoter is often tested as well, or EGFR amplification, or chromosome 7 or 10 gain, chromosome 7 gain 10 loss, which are diagnostic for molecular features of glioblastoma. And it's really this integration, these two features, the histologic data, what the cell architecture appears like under the microscope, in combination with the molecular features, that gives us this integrated diagnosis based on the updated World Health Organization 2021 criteria for neuropathology. And the disease is now referred to as grade 4 glioblastoma IDH wild type. This is very important because we're talking about two separate things here. There's a point where you have an MRI scan that is suspicious for glioblastoma or has suspected glioblastoma. Then you can have a biopsy or a surgery that has tumor on it, but doesn't meet criteria for glioblastoma. And there are a series of tumors which are cancers and they need treatment, but they're not glioblastoma. And so I want to just list some of them here because these are common other tumor types which are distinct from glioblastoma. These are IDH mutant astrocytoma, IDH mutant oligodendroglioma. There's histone K27M mutant diffuse midline gliomas, or BRAF altered diffuse gliomas, also called MAP kinase deficient, MAP kinase altered diffuse gliomas. These tumors are gliomas and they need to be treated, but they're not glioblastoma. So they're a different subtype of disease. And that's really what the benefit of the WHO 2021 criteria has been, which is that we now are much better at cleanly defining the categories of disease and moving patients from that uncertainty of the first MRI scan to a certain diagnosis so that we know what disease they have, and then we can try to do the treatments that are best for that patient. So the take-home message of this first part of the talk is that not everything that glitters on an MRI scan is glioblastoma. There's many scans that can look concerning, but you really need to work closely with the team to make sure that the initial diagnosis is accurate. So that is a key message that I would say happens in the newly diagnosed setting. The second goal of surgery, which arguably is the one that we always focus on the most, is the step of treatment. So one of the reasons we do surgery is we want to take out the tumor. Obviously, the tumor doesn't belong there. We want that to come out and try to get as much benefit as we possibly can in terms of resecting the tumor. And we want to be aggressive about that. Certainly, there's many studies that show that taking out more tumor as much as safely possible is beneficial to patients. And so that's the therapeutic goals of surgery. This is the thing that we really focus on, how to do the surgery using all of the techniques that we have to do surgery well to get the therapeutic benefits. We want to extend patient survival. We want to either reverse or preserve neurologic function for as long as we possibly can. The way we achieve this is by cytoreduction. So what we're doing when we do a glioma surgery, a glioblastoma surgery, is we're removing the tumor cells, as much of the tumor cells as possible. A frequent question that comes up at this point is the issue of how do we take out all of the tumor cells? How do we set the margin around the tumor cells? And intrinsic to the biology of glioblastoma is that it's never possible for us to completely remove all of the tumor cells from a glioblastoma. There's always going to be cells that are escaped or beyond the margin, even outside of the area that's enhancing on the MRI, or outside of the area that's non-enhancing on the MRI. And these cells are infiltrated amongst normal brain cells. And so the complete removal is unfortunately never possible for a patient who has glioblastoma. So what we're talking about when we're saying we're going to take it out, what we're saying is we're taking out the right amount, or the amount that by the evidence is most beneficial for the patient. We have a lot of studies, a lot of data and retrospective studies, and in some prospective studies, looking at clinical benefit of how much surgery is beneficial for patients. And all of those data point towards aggressive surgery being beneficial for patients. For diffuse gliomas, we're trying to balance maximum tumor removal with preserving normal function, and making sure that we help patients, we don't hurt them, we don't cause undue neurologic deficit by pursuing aggressive tumor resection. There are many surgical adjuncts that we have available to us that allow us to pursue more aggressive resections and to take out enhancing tumor that would otherwise be left behind without these agents. So there's things like 5-ALA, which is a fluorescent dye that can be used to help mark areas of tumor and make sure that they're not left behind during surgery. That's Gliolan. There can be intraoperative imaging modalities. So these are things like ultrasound or intraoperative MRI scanning. We use these methods in difficult cases or complex cases where the anatomy of the tumor can be either changed during the operation. So for cystic tumors that collapse during the operation, so then the features and the edges of the tumor have changed, we can update our imaging during the operation and check and see where the tumor edges have moved to, so that we can then resect those as well. And then also for tumors that are kind of indistinct around the margins or have unusual anatomy, where instead of being round, they kind of have extensions. These methods are very good for identifying those edges and making sure that we can resect them safely. There's also the opportunity to try to intervene in the upfront setting. And so there's this agent called Gliadel, which is a wafer, a carmustine wafer. It's a pledget that can be placed within the tumor cavity. And there have been studies showing that this is a potential treatment option for certain patients based on the tumor anatomy. The key here is that these types of surgical technologies are individualized. And so some types of tumor anatomy in some patients really don't fit or don't need or don't fit the requirement for using these types of agents. And there can be all kinds of reasons for that. Sometimes tumors are located in areas where we expect the surgery to go very smoothly, and we are not concerned about the edges because the anatomy of the tumor is very straightforward to understand. And so in those types of cases, what we're trying to do is minimize the length of the surgery, to minimize the risk of complication. And so then we don't have to use surgical adjunctive options. And in other cases where the tumor anatomy is complex, but they're good candidates for these types of agents, then we do use them. And so the key here is to recognize that there's no standard best way to do the surgery. Best way is whatever the best way is for that patient and for that tumor. And that's really what happens at surgical cases, is we try to individualize the case so that it is the best for that particular person. And so when we talk about these technological adjuncts to surgery, we recommend consideration of them, but they have to be tailored to the specifics of the case. So after the surgery, we talk about what the recovery course is like. What's the typical recovery? Most patients, the recovery is a couple to several weeks. So for those patients who presented with neurologic deficits like weakness or difficulties with speech or visual spatial sense or other types of neurologic effects, we're looking to see how much improvement we can get from the surgery. So as we take away the mass and we relieve the mass effect of the tumor, the brain then slowly over the next few days to weeks moves back to a more normal position where it's been displaced from. And we try to see the resolution of the neurologic deficits that then come with that as the brain kind of returns back to normal. Sometimes we have to look and see if a second stage surgery is needed. Sometimes for these very complex and distorting tumors, there'll be a first stage surgery that takes out, a significant portion of the tumor, but not all of it, and more can be done. And then especially as the anatomy kind of renormalizes, it becomes more clear that a second stage operation would be helpful for that patient. And so then we look at that at that point. Then there's the question of wound healing. So a patient will always have an incision from the surgery, and we look to monitor to make sure that that incision is healing well. As everyone knows, every surgery has a risk of infection with it, a risk of that runs about 1 to 1.5 to 2%, on all comers. And so we watch that closely. The peak incidence of detection of a wound infection from surgery is usually around 2 or 3 weeks post-op, right around the time where we look at the staples to take out the staples or the sutures. And we look at that time to really see, is the wound healing nicely? Is there any risk of infection? That's a key thing to monitor. And the other thing that we do during this window of time when patients are recovering from the surgery is we want to ensure the accuracy of the diagnosis. So I'm kind of returning back to that first part of the talk, which is we want to make sure that all of the pathology tests that needed to have been done in order to really, efficiently and accurately categorize the tumor into either the glioblastoma IDH wild type group or one of these other groups has been performed, so that then we can put together a plan of attack in terms of the subsequent care. Lastly, and then this is probably one of the most important things to talk about, is after that first whirlwind of diagnosis and surgery and then recovery of surgery, in those weeks where the diagnosis looks like it's going to be glioblastoma IDH wild type, this is where we really want to work together as a family, as a patient, as a caregiver team to get ready, planning for the logistics of treating a serious illness. Glioblastoma requires lots of different treatments, and it's a heavy logistic burden. So you want to work on home and living arrangements, preparing your family for care support that will need to happen during that time. For our younger patients who are, younger couples, thinking about fertility planning as you go into the potential for needing radiation or chemotherapy treatments, healthcare proxy documents, all that kind of documentation that we're always supposed to have, but we've always put off. Having those discussions with your family about advanced care planning and end-of-life documentation, preparing time away from work for you and your family so that you can participate, in the treatments without having disruptions, and all the transportation issues that are associated with treatments if you're going to need daily radiation or things like that. So this is the key window of time where you try to gather all of those resources together and get ready for the treatment that's going to be needed for this illness. So now I wanted to talk a little bit about the common side effects that can happen after surgery and for patients who have glioblastoma. One common side effect that we see is seizures. So a certain subset of our patients present with seizures, and others could potentially be at risk for seizure going forward with a lesion in the brain. And typically for seizures, we can give medication that will treat or decrease the risk of seizure. And these medications can have side effects. So the common side effects associated with medications are really depend on the specific medication given. A very common medication that's used is called Keppra or levetiracetam. This can cause, in about 20-25% of patients, 20%, it varies obviously, can cause some fatigue or sense of slowing. Sometimes patients will call it a fog in extreme cases. And this can be helped by either lowering the dose or changing how we administer it. So we kind of lower the dose in the morning and increase the dose at night in such a way that where we try to minimize the impact of that kind of slowing effect on patients. There's other seizure medications that can be used as well. So if patients are intolerant of Keppra or a baseline agent that is started, you can switch to a number of different other agents. These, again, have idiosyncratic or different side effects, and there can be monitoring needed in the use of these medications. So blood tests like a blood count or electrolytes just to monitor to make sure that there's no problems, or sometimes EKGs or other tests are needed to make sure that there's no side effects from these medications. Seizure medication is not required in every case. So sometimes patients don't need seizure medication of any kind. Sometimes patients need seizure medication just around the time of the surgery, just be protective of the brain as there's a lot of shifting occurring associated with the surgery, but then they can stop the medication. And other patients, especially if they present with seizure, typically we try to make sure that we keep a basal level of seizure medication on board for at least some time around that initial diagnostic phase to prevent against the risk of another seizure. Another common side effect, which we alluded to before, is this issue of headache or neurologic symptoms, so weakness or other difficulties with speech or visual spatial sense. So there can be improvements in these deficits after surgery as the brain kind of returns to more normal after the tumor has been removed. Typically, there can be some permanent residual effects, and this is related to this concept that I talked about where the tumor has infiltrative qualities to it. So it grows in amongst the normal cells. So even after you remove the main tumor mass, sometimes there can be normal cells that have been disrupted or infiltrated by the tumors, and then that will lead to a residual deficit of normal function. So patients, are fully normal before the diagnosis. They start to develop deficits, and then they have the surgery and they get better, but they may not get all the way fully back to normal again because the tumor has caused some permanent deficits. Typically for treatment to try to help with this as the process, to help with the swelling that's caused by the tumor's invasion and also the swelling that's caused by having surgery, we will typically use high-dose steroids in patients to help offset a lot of these symptoms. The steroids have lots of side effects. This is something that is these are very powerful medications, so they're very useful in the management, but they also have a lot of side effects that comes along with that. And so we will then try to taper or decrease the dose of steroids in that postoperative recovery period. The types of side effects are very reproducible in patients. So patients will feel that quality of a surge from the steroids. They feel jazzed up or pressured or anxiety, pressured conversations. They have difficulty sleeping and they find themselves being almost like hyperactive just as a result of the jitteriness that comes with the steroid medication. There can be weight gain associated with eating or fluid shifts, fluid retention from the steroids. Longer-term steroid use can lead to either problems with skin or muscle wasting, and there's a risk of infection, a risk of a lung infection with a long-term steroid use. And so often for patients who are on steroids for a longer period of time, they'll take prophylactic antibiotic type medication like Bactrim or some other medications like that to try to help minimize the risk of a long-term of an infection associated with long-term steroid use. Stopping and restarting steroids across the course of treatment is very common. So a lot of times it can be hard to predict how fast the brain will kind of come back to normal after a patient has had a surgery. And so a steroid taper, a decrease of the dose, a schedule will be made, but it's not perfect. And then we'll realize that, oh, we need to course correct and then change the dose of steroids, increase them a little bit again, and then decrease them at a different rate or a different timing. And so everybody will commonly experience this course correction phenomenon where we're changing the dose of steroids afterwards in an attempt to try to optimize for that particular patient. It's also common that once we're able to get patients completely off steroids, it can be off for a while. And then in the future, if they develop problems, we may need to restart steroids. So stopping and starting steroids is a very common feature of management. The other common side effect that we see or we try to offset and watch out for is the risk of blood clots. And these are referred to as DVT or deep venous thrombosis, these blood clots in the legs. And this can give rise to pulmonary embolism or PE, which can be life-threatening as the blood clots migrate to the lungs. There's increased risk in patients who have IDH wild-type glioblastoma from multiple factors. So there's something about the biology of the tumor itself that promotes clotting. It promotes a quality of blood to be thicker. And so just generally speaking, patients who have glioblastoma, they have a tendency towards more blood clots. Secondly, if the tumor is causing any weakness or immobility, that lack of movement of the limb, the leg, the arm, or the leg can cause problems with blood pooling, and then that also can lead to a risk of clotting. And there can be a variety of other patient and medication factors that can contribute to patient, having clotting a risk. And so it is very common in patients who have glioblastoma that they need to receive medications to either prevent as a prophylactic agent to try to prevent or to treat blood clots. And we have to do this very carefully because we have to balance against the risk of bleeding, certainly bleeding into the tumor or bleeding elsewhere in the body. And this is a common trade-off that we have to closely monitor in patients. And so the types of medications that we use are either these injectable medications such as heparin or Lovenox, sub-Q heparin or sub-Q Lovenox, or oral drugs such as factor Xa agonists. These can help minimize the risk of blood clots. So those are some of the common side effects associated with surgery. Now we're going to talk about building your team. So after your surgery and a confirmed diagnosis of glioblastoma IDH wild type, there's a care transition. So the neurosurgeon has done the operation. Pathology teams have confirmed the diagnosis of glioblastoma IDH wild type. And now a neuro-oncologist and a radiation oncology team, those two teams will be formed to try to take over your care and join your team and care for you going forward. The standard of care for newly diagnosed glioblastoma most commonly includes both radiation treatment and temozolomide, which is an oral chemotherapeutic agent. It's a pill. This can vary. Some patients' tumors can be better treated with different courses of radiation, so 6 weeks or 3 weeks, different timing or fractionation, how they break up the doses of treatments. Some patients' tumors and tumors are better treated without radiation, and they should just receive chemotherapy. And so this just depends on the specific patient and the specific tumor types, whether they're MGMT methylated or unmethylated, and their overall, the overall picture as the neuro-oncologist and the radiation oncologist evaluates the best treatment for that patient. There's other options that can be used in this upfront setting, such as Optune or which is the NovaCure device. How soon to get started with treatment? So this is a common question that we encounter in patients after they have received the diagnosis of glioblastoma, which is, how soon should I start? Is starting sooner more beneficial? And so there's a little bit of a trade-off. You have to recover from the operation, and that incision that you have from the surgery has to heal before we start the intensive radiation treatments that are associated with glioblastoma. So if you start too soon, there can be risk of poor wound healing or having the incision break down or become infected during the radiation treatment. And there is not a good evidence in many studies that there is benefit to starting too early or starting sooner. Most studies show that the beneficial window of starting treatment it starts around 4 weeks or so after surgery, up to about 8 weeks after surgery for starting radiation chemotherapy. And this is probably that sort of collective window that it's the best time for balancing wound healing with developing a risk of tumor growth during that recovery period. Obviously there's a range of outcomes here. The key is to recognize that you want to be able to start radiation and chemotherapy and then also finish radiation and chemotherapy without a complication developing during that time window. And so trying to optimize the start date is really also trying to optimize the entire course of that treatment. You don't want to have the treatment disrupted by having a wound issue, and then you have to stop radiation and then get the wound repaired and then restart radiation again. It would be better to just wait another week and let the wound heal further and then start treatment at that point. Okay, common side effects with treatment include monitoring of blood counts during radiation and especially temozolomide treatment. Some of the side effects from chemotherapy can lead to lower blood counts, and so typically these will be monitored closely by the neuro-oncology team. The thing that is probably the top noted side effect during radiation chemotherapy treatment is the fatigue. Patients, especially as they get further into their treatments, patients will notice that there can be some tiredness, pretty substantial tiredness associated with the treatments. And then some patients do notice some short-term memory difficulties as well. These usually will get better, but this is a side effect that is noted by many patients. So now expected outcomes. Certainly, it's a serious diagnosis. When we talk about glioblastoma, we know that this is a significant and an aggressive cancer. The outcomes, though, can be highly variable from patient to patient. And the survival that we look up, when we look at the median survival, is really just one number, which is the median, which is the point at which half of the patients have survived in large studies of treatments. And so it's really important to recognize that that number really has no meaning for any one patient. Individual patients can survive much longer, and unfortunately, they can survive shorter as well, based on how their tumor responds to treatment. And that's the key, I think, that's the key difficulty with, as we enter this treatment phase with patients. So the disease is very serious, and each patient experience is different. So uncertainty is very hard. You have to plan for a range of outcomes, some of which are very poor, some of which are very good. And you have to be open to the possibility that as we learn about the tumor and how it responds to treatment, that those are all in the range of possibility. And so the key is to try to build your team so that you can maintain flexibility and keep hope as you go into this treatment and we learn about how the tumor is going to respond. Okay, so now let's talk about participating in experimental research. So depending on the tumor subtype, for example, MGMT methylated or unmethylated tumors, you can have the option to participate in studies of experimental research treatments. Trials are run at many different centers throughout the country, and the best place to look for this is on clinicaltrials.gov, which is the government website through the NIH that all of the trials are registered on. And then there's a large trial network that's run by the National Cancer Institute called the National Clinical Trials Network. Specifically, the NRG Oncology Group and the Alliance for Clinical Trials in Oncology organizes the large national studies of clinical trials for brain tumor patients. And so many patients who are interested in participating in experimental research therapies, so therapies beyond the standard of care, will look at these sites to try to identify an appropriate treatment if they're a candidate to be treated on a trial. There's really two key entry points for patients in the research setting. One is in that upfront diagnostic situation. So as a newly diagnosed patient who's just starting their initial treatment of their tumor after the first surgery. And then the second point is if a patient then has completed the initial standard of care treatment and is on monitoring after that treatment, if the patient has tumor regrowth or recurrence after having already received the standard of care, there's a huge list of potential options, experimental options at that recurrent setting where there's no longer a standard of care for treatment. And so this would include window studies, so patients would receive drug prior to a second surgery, patient receiving intraoperative agents at that second operation. So drugs like I'm sure many patients have heard of, such as viral therapies like poliovirus or other types of viral therapies, brachytherapies, there's a radioactive seeds or tiles placed within the surgical cavity, things like that. These are all potential options in the recurrent setting. The key to understanding experimental research is that while there's a rationale for us hoping to have benefit from these treatments, there isn't any proof yet. So that's the key. Experimental therapy is experimental. We don't understand the side effect profile of these treatments often as well as we understand the standard of care side effect profile. And many options can be reasonable for a patient. So a patient could be candidates for many different options. And we have no great way to pick one treatment over any other treatment for that patient. And so guiding cases and picking experimental treatment options is highly individualized. And there is no such thing as a one size fits all where we say this is the best experimental option for all patients. That's just an unknown thing for this disease. So in conclusion, I think what would you do for yourself or your family member? Often patients will ask me this: what should we do? Or what would you do, Dr. Cahill, for your family member if they had this disease? And what I would say is I would seek treatment with an experienced team that is close to my home. And the reason for that is for all the logistic considerations that I talked about. I want my family to be able to help me get through treatments. I want to be able to marshal the resources of my local community to help with all of the things that need to be done for the logistics of care. I want that team to be experienced so that they see enough cases, that they recognize what are the common issues that arise in patients, and they also have enough experience to recognize the outliers or the features that are unusual or don't fit the pattern, and so that they can, the alarm bells start to go off and they recognize that this is an unusual situation. I would say that if there's any doubt, and I certainly recommend this to all my patients, if you have any doubts at all that your team is not, going to be fitting all of the things that you want, this is the right time to seek second opinions. And really the goal of those second opinions is to be able to be confident in that local team that you're going to be working with as you move through the initial care of your treatment of tumor. And so it's at this point, once I've settled on that initial team, it's there where I would have that discussion about, am I a candidate for trials? Should I be looking elsewhere? And if they referred me elsewhere, I would then set that referral up in such a way that they would work with my local team, because I'm ultimately coming back to my home, which is where, even if I'm getting an experimental treatment elsewhere, I'm going to be living in a place where my home team is going to be taking care of me. So I would try to make sure that that was all set up in an appropriate context. And the key to understanding this is that as a team of doctors, we all work together. So we work together across the entire country to take care of patients who have glioblastoma. And very commonly, we have patients who, receive an experimental treatment at one site, an experimental treatment at another site, and their home site is a third place. And all of us know each other within the field, and all of us as doctors and nurses are working to fight this cancer together. And so that's what we would do for any patient, and that's what I want patients to understand, that we're all doing together. Okay, thank you very much, and I want to take any questions at this point that you might have.
Thank you so much for that presentation, Dr. Cahill. As a reminder, if you do have questions that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we will answer questions as time allows. All right, so one of the first questions we have here is talking about side effects. So you mentioned how some effects may improve over time after surgery, after treatment has begun. Some may not, some may linger a little longer. How common are late effects with glioblastoma, effects that maybe the patient didn't experience initially, but now they are experiencing maybe a few months later? And can you also, it's kind of a two-part question, can you also talk about how you as a physician can determine whether those effects are late effects from the treatment or the tumor, or if it is tumor progression and growth?
This could be a challenging issue with patients who have glioblastoma. So the treatments are very aggressive, obviously the radiation chemotherapy, and there can be these phenomenon after that treatment referred to as pseudoprogression, which can happen relatively early, or there can be late effects from radiation or response to radiation, scarring that can occur. And so as patients are living longer and longer, we can start to see more and more patients experiencing these late effects from tumors or treatment, that mix of issues. And so it depends. The key to determining the difference there is the impact on treatment. And so there are a number of situations where there'll be a change on the scan and the patient maybe is doing okay, and then we can just watch and see how that change evolves. But if there's a change and then the patient is having symptoms or having side effects, let's say, or having an alteration of neurologic function as a result or in association with that change, in some cases like that, a biopsy would be needed to try to steer the treatment based on whether we're seeing more signs of therapy-related changes, inflammatory change, let's say, or if we see signs of recurrent tumor. And so that's a good scenario where, your team then would kind of return back to the neurosurgical team and say, okay, do you think a biopsy is needed in this case? And then we would try to set up for that. I'd say about, in my experience, maybe about 15 to 20, 25%, 15%, something like that, of patients who are newly diagnosed with glioblastoma will eventually need a biopsy at a subsequent time point because there's lack of certainty as to what's going on with regards to the late effects. So I hope that answers the question.
That does. Thank you so much for providing that insight. Another question we have here is on recurrence. Can you talk a little bit about the risks of recurrence? I know you talked about the personalization of medicine, looking at the tumor profile and pathology. Are certain glioblastomas more likely to occur? Is there like an average frequency of recurrence that you're aware of that patients, newly diagnosed patients, should keep in mind or be aware of?
Right. So this is again, this is a challenging thing with this tumor. So as we talked about, the biology of the tumor is such that there's no surgical procedure that can remove all of the tumor cells. And so even if the MRI scan looks perfect after a surgery and it shows that all of the areas that we can see that look like tumor have been removed, we know that there's tumor present. And so the way I try to think about recurrence is almost time to recurrence. I almost plan for recurrence at the very beginning because we know that there is, because of the intrinsic biologic residual of these tumors, there is going to be the chance for recurrence really at all points in the future for every patient. And so then the question is about the frequency, or how long, what is the timing of that? And the key there, the key factor that people have identified is this MGMT methylation. So methylated tumors, there tends to be a longer time before recurrence compared to unmethylated tumors, which seem to recur more quickly. Now that's obviously there's overlap there. So this is on a cohort basis, but in general terms, the methylated tumors tend to have longer time to recurrence compared to unmethylated tumors. Here, though, I think as the questioner said, there's highly individualized outcomes. So sometimes you'll see unmethylated patients and they go a very long time and they haven't recurred, but we still worry about recurrence in them because we worry about recurrence in every patient.
Thank you so much for sharing that. Another question we have here is asking, is there ever a time when surgery is not appropriate or indicated for a newly diagnosed glioblastoma? And if so, can you touch on some factors that may impact that decision?
Yes, that's right. So the key here is that the way we approach surgery is what is most beneficial for that patient, right? What's the best way to get the best outcome for that patient? Some patients either have multifocal or widespread disease. Some patients have disease that's located in critical functional areas so that any attempt at resecting that area would lead to a life-threatening neurologic deficit. Typically, we try to make the diagnosis in patients like that using biopsy techniques, so where we try to do a minimally invasive procedure and get a piece of diagnostic tissue, something that we can look at the tissue architecture, something that we can test for the mutational profiles, and still try to efficiently guide the care of that patient, even though we're not able to safely resect the tumor for that patient. And that's sort of the consideration that goes into it. I would say for biopsy-only patients, especially patients that we prioritize for biopsies, there's some advantages. They don't have to wait the full amount of time for the surgical wound healing in terms of recovery because the biopsy incisions are very small. And so we're able to usually make a diagnosis and then get that patient started on treatment much sooner. The disadvantage is that by its nature, the cases that we're biopsying are ones that are difficult from a neurologic standpoint. And so that those are often patients who can run into complications on the sooner side with regards to seizure or weakness like we talked about. And so it really ends up being an individualized patient management issue with regards to surgery. Obviously, for any patient, we would like to be able to operate and resect as much tumor as possible, but we have to approach the tumor what it gives us, and then do what's best for that patient to make them, to give them the best chance for long-term survival.
Thank you so much for that thorough answer. Another question we have here goes back to what you shared about that time frame between surgery and starting treatment. I believe you had mentioned It's usually between 4 to 8 weeks of when you would recommend starting treatment. Is that something that is standard? Is that a global consensus that that time frame is recommended for waiting before starting treatment?
Yeah, I mean, I think that, so again, it's just what I'm trying to stress with that is, so the studies show that that is the time window. It's approximate time window. There's variation amongst the studies. The types of patients who start sooner are ones who where like I said, this recovery from surgery is quicker. So the incisions, maybe it's a biopsy only case, or there's residual disease where we'd like to start treatment on the sooner side, things like that. It is true that sometimes patients take longer to recover from surgery. You only start to see an impact on survival for that longer time after about the 8-week mark or so. So, what you want to do is you want to move through that initial diagnostic phase in a careful and efficient manner so that you don't have to go back and repeat anything, because then that disrupts the time frame going forward. And so that's really what the message that I'm trying to convey with regards to the 4 to 8-week time frame is. You want to make sure that you have a good surgery. You want to make sure that if you need a second surgery, you have that one. Then you recover from those, and then you start treatments, and that you don't have to go back and repeat any phase that happened beforehand. So.
Thank you so much. Another question we have here is regarding the WHO 21 guidelines. If a patient was diagnosed previously a few years ago with glioblastoma, and now during reassessment, it is determined that it's IDH mutant, for example, and not wild type, is it still considered glioblastoma? Is it considered grade 4 astrocytoma? Does that impact what their treatment and management looks like?
Yes. Yeah, so this is a key change from the WHO 2021 and is an important, I think, advance for the field, but it's a transition issue as we have changed to the new 2021 criteria. So the new criteria reserve the word glioblastoma for just patients who have IDH wild type disease. You can still have advanced IDH mutant disease, and they're calling this grade 4 astrocytoma as a way to try to convey that important data. But this patient has a different disease process from glioblastoma going forward. We're going to call glioblastoma just IDH wild type patients. The reason that's important as a field is that it means that we're going to start designing trials specifically for patients based on their specific subsets of disease. So the trials are just going to be for glioblastoma IDH wild type patients. There'll be specific trials for grade 4 IDH mutant astrocytoma patients, specific trials for histone mutant patients. And so instead of mixing everybody together and applying a treatment which might only really work for one subgroup, we're going to try to pick treatments that have the appropriate rationale for that specific subgroup of disease. That's going to be a big advance, I think, going forward. I think managing through the transition is going to be tricky because we're going to have patients who had a diagnosis in the old legacy criteria, were partially treated based on those criteria, and then now we're updating the criteria in the middle of this patient's treatment, and we have to figure out how to course correct on an individual basis.
Thank you so much for providing that clarification and better understanding. Another question we have here is talking about imaging. Is there a standard of when repeat MRIs and imaging is done as you are undergoing ongoing maintenance and treatment to reassess tumor growth, progression, or improvement?
There are standards that are written into the guidelines. I can't quote them because as a surgeon, I don't drive that decision making. That's driven by the neuro-oncologist and the radiation oncologist. But I would say what I see in my patients who are under the care of my colleagues is they'll typically scan people every few months. So it's in that range of every 3 months or so, patients are undergoing scans. And they're looking for enough time to elapse so that if there is a change, it's detectable on the MRI scan, so that we're not scanning people every day and have a no change between days. But then we don't want it to be too long so that if there is a change that we miss it. And so that's how the consensus was made for that. As patients get further out in their treatment, and we learn about their tumor. So if there's a patient who has a very slow growing or non-aggressive tumor, just by luck, sometimes I've seen my colleagues then start to spread out the time in which they scan patients. So sometimes they'll start with shorter interval scans when they first meet a patient, and then after they've known somebody for 2 years or 3 years, something like that, they might start to extend the interval of time that they follow the tumor, because they've learned for that particular tumor and that particular patient, it can be a longer time frame and still be safe. So.
Thank you so much. Another question we have here is asking, how do you know when treatment is not working? What do you look for? Are you looking for continued tumor growth, deterioration, increased side effects? What are factors that you are looking at to determine whether or not treatment is working?
Yeah, that's a good question. So if a patient has measurable disease, so they have evidence of disease on the scan, then what we look for is either shrinkage of that disease, which we call response rate, or stability, where the disease doesn't change over time. Also, there's the other factors that are involved in determining how patients do is how is the neurologic function doing? So is the neurologic function been stable or improving, or is it getting worse? There are specific criteria that are used to measure whether there's a response. That's called RANO criteria, Response Assessment in Neuro-Oncology, RANO. And the third part of these criteria is the use of steroids. So if you have a requirement, a certain need for steroids, or if you haven't been on steroids and then you have to start on steroids because of having neurologic side effects, that can be considered evidence that there has been worsening of the tumor. So these are the types of criteria that are used, and then how we make official determinations of whether a patient has has had a progression event or not. But we try to set it so that small changes in the MRI, things that might just be evolutionary changes, or resolving surgical changes, or minor changes in the tumor, are not enough to say, okay, we should abandon this treatment at this point. And so often what we'll try to do is start a treatment and then commit to using it for some time. Even if we see minor changes in the scans, we try not to change course just with that. So.
Thank you so much. We have a question here asking about what are some factors that patients and families should keep in mind as they're trying to find the right treatment and care team for themselves. You mentioned the importance of having that confidence in your care team. What are some things that they should look for, maybe some questions that they should ask to determine whether or not the care team is the best one for them?
Yeah, I mean, so what I would say is, you want an experienced team, and typically the types of things that I look for, or I would ask, is, what has been your experience with other patients, and how do they manage? So really concrete things. How do they manage getting to radiation treatments? How do you manage the receipt of chemotherapy treatments? And experienced teams always have good answers for those questions, because they have done it, and so they know what the pitfalls are going to be and how to avoid the pitfalls and how to work their way through these problems. And so, I would just start to talk really about the concrete day-to-day questions associated with treatment, and, reach a comfort level with your treatment team about how exactly the treatment is going to happen for you, and what are the logistics going to be like? How are you going to get there from your home? How are you going to get to treatment? How is this all going to work? And good teams have good answers to those questions, because they do it all the time. So.
Thank you so much. And kind of a follow-up to that, you talked about second opinions and how those can be important as well. Can you maybe provide some advice for patients who are undergoing a second opinion, maybe even a third opinion, and they have differing opinions from each care
Right.
team? How do they make the decision of what is best for them and which decision to go with?
Right. So I, as a physician, I participate in these opinions, second or third opinions. And what I try to do is to just be very open about the fact that, there can be differences, there can be discrepant thoughts about how to manage specific cases. And I tried to allude to this in my talk as well. Once you're at a stage where there can be experimental options or there's no standard of care, the advantage is that we could do anything, but the disadvantage is that you can then get a lot of opinions that can differ from each other. And so what I try to stress to patients at that time is that obviously you do have to make a decision, and that can be difficult, but also that you have to remember that all of the doctors are on the same team. We're not competing with each other. We're all just trying to think of the best way to take care of your tumor. And we each have thought of one option for you, which may or may not be better than any of the other options. And all we're trying to do really is to work together to try to figure out what would be a good option for you. And, in the end, you just have to be forthright with the patients, with the other teams, and say, I see it this way, you see it that way, and just do the best we can for any given case. And I like to be as open and forthright about this. If my patients are seeing other physicians, I think that's a good thing. I think you want to try to learn as much as you can about different options, and then really pick what's best for you based on what's available.
Thank you so much. I think we have time for just one last question. This question is talking about clinical trials, experiential treatments, as you just mentioned. When is that usually brought up? At what point, once a patient is diagnosed, are clinical trials brought up as an option?
Yeah, so like I said, there's sort of two entry points into that universe. One is in the upfront setting. So as you settle on your initial neuro-oncology and radiation oncology team, in that time, a few weeks after the first surgery, you'll go through a discussion about the standard of care. And then at that point, you can also additionally talk about whether there are experimental options that you might be a candidate for. And so I would say either at the end of that first visit or during the second visit, as you're putting that team together, that can be part of that discussion. Now, it may be that based on your specific setup, that standard of care is ideal for you, and that the best entry point for you to get involved in experimental treatments would be if you have a recurrence, so later. And so then at that point, again, that kind of discussion with your local team would be, okay, I'm going to do the standard of care in the initial setting. I don't want to enter into an experimental treatment at this point, but I might want to enter into the future. And then, if and when you have a recurrence, if you can get a plan in place for considering experimental treatments in that setting, and you can work on that during your standard of care treatment course, that can be a good use of time. One thing that can be very challenging is if you have a recurrence, there can be so many different options for experimental treatment in the recurrent setting that if you haven't thought about some possibilities, it can be just logistically difficult to keep up with all the different options. And so it's a way, this is a very challenging thing to do because there's so much uncertainty with how a given tumor is going to respond. But one thing that my advice is you try to really prepare for many different possibilities. And so you think about, okay, if a recurrence happens in 6 months, maybe this would be an option. If a recurrence happens in a year, maybe this would be an option I would look at, and sort of think about getting those ducks in a row, in discussions with your primary team as you move forward.
Thank you so much, Dr. Cahill, for that insight and for that important advice as well. That is all the time that we have for questions for this webinar. Again, I want to say thank you, Dr. Cahill, for taking the time out to share your insight and your expertise with our audience today.
Thank you very much for the opportunity.
In addition, thank you to our webinar sponsor, Medexus Pharma, for their support of this program, and a special thank you to each and every one of you for joining us online today and sharing your questions. We hope you've found this webinar to be informative and beneficial. We encourage each of you to take a few minutes to complete our webinar survey by scanning the QR code on the screen or going to the link here. Your feedback is important to us as we plan for future programs. You'll also be receiving a link to this survey along with our webinar recording in a follow-up email message in the next few days. If you're looking for more content like this, please check out our national conference. This free 2-day program, taking place September 8th and 9th in person in Chicago and online, features a slate of educational sessions like this one, personalized breakout groups, and networking opportunities. Learn more and register for free using the link on the screen or scanning the QR code. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. This now concludes our webinar. Thank you so much for joining us and enjoy the rest of your day. You may now disconnect.